for this online webinar monthly meeting organized by Indian Society of Study of Pain, Pune. Our seasonal greetings for Navaratri and Ghatastapana to all over India. Namaskar to all of us for this auspicious day. And we are having an auspicious meeting. I welcome our guest speakers, Dr. Anurag Agarwal. And I'm very thankful that he has spared his time and to attend our monthly meeting, which is online, as Dr. Siddharth Verma will join shortly. And this topic which we have selected is minimally invasive spine interventions by pain physicians. Though it has been carried in a very big way in all over India by all various pain physicians. In Pune, we have more than 35 pain physicians. And few are doing it. I want to stimulate that the rest also follow the footsteps of Dr. Anurag and Dr. Siddharth. And many can go and learn and do fellowships, do workshops. So without wasting any time, I'll hand it over to our moderator for the today, Dr. Amol Pailwar. He is MD and Chronic Pain Fellowship lead from Dept, and he's working with us at KM Hospital, Pune, as a senior lecturer with us. So welcome, Amol. You can start the meeting as a moderator.
Good evening, sir. I welcome all you all on this SSPP monthly meet. Actually, our topic for today is advanced spine minimally invasive pain and spine interventions for pain physicians. As we all know, nowadays we get new advanced techniques, new literature, new methods in pain medicine. Every day we are getting this. But now many of the pain physicians now started following this, performing this minimally invasive pain procedures for like vertebroplasty or microscopic endarterectomy to elevate the pain. So our topic for today's webinar is same, advanced spine MIPSI for pain physicians, and we have got our stalwart speakers with us. So our first speaker is Dr. Joyshankar Jana, sir. Sir is senior consultant at KM Hospital, Pune and Galaxy Care Hospital, Pune. Sir has got base paper presentation for anesthesia for robotic surgery in MIPSI 2010 as well as SSPP 2010. Sir has 4 international and 2 national publications. His areas of interest are anesthesia for robotic and advanced laparoscopic surgery, anesthesia for cochlear implantation, anesthesia for kidney, liver, and uterine transplantation. He was governing council member of ISA National Headquarters from 2016 to 19, governor council member of ISA Maharashtra State from 2012 to 16. He is honorable of Pune City as well as he is honorable president of ISSP Pune City. He was team member of the anesthesia team for the uterine transplant as well as the cesarean section for after uterine transplant, which was done first time in India and Asia. Welcome, sir. I welcome Dr. Joyshankar Jana, sir, for his talk on overall review of spine MIPSI by pain physicians.
Thank you, Amol. So I will start by sharing my screen.
The screen is visible if you can full screen. Okay.
Yeah. So very good evening to all. I welcome you all on this online webinar. This spine minimally invasive surgery for pain physician in overall view. It has been a very big response by the pain physicians. Yes, they have taken over the minimally invasive spine surgeries. So the pain physician in India should at least, in Pune, should at least start thinking about it, about starting spine MIPS. So those some of them are doing it, but I want the youngsters to get motivated and start doing it in a big way. It is done all over India. So the spine MIPS is done by either spine surgeons, orthopedic surgeons, or neurosurgeons, and now, of course, the pain physicians. Now, whether pain physicians or whether they can do minimal surgery is another different level of a different debate. This debate has happened in many, and there were many panel discussions in very ISP on whether pain physicians are. This is a different debate. So all spine MIPS are named differently by different persons, by whether neurosurgeons or by orthopedic surgeons. They are named differently. The one will say, but the operation is the same, but there are different names. So ISSP has developed a unique system of uniformly making the terminologies under one roof. So this coding system was approved by ISSP. Of course, Anurag was one of the members while doing this coding system. Of course, it's a huge list, but I'll be just enumerating the various procedures which are done by pain physicians in spine MIPS. So if you see vertebral augmentation, cervical, thoracic, lumbar, unipedicular or bipedicular approach, sacroplasties, bilateral or unilateral, vertebral augmentation with balloon, either the thoracic, lumbar, or sacral areas. Then neurostimulation, it could be spinal cord stimulator, dorsal root ganglion stimulator, and sacral nerve root stimulator. Intrathecal drug system delivery systems are intrathecal ports, intrathecal pump implantation, intrathecal trial drug administration, epidural catheter placements, epidural external port placements, and intrathecal urinalysis. Of course, intrathecal pump implantation was one done in Pune by Uttam Sidhe sir. And it was a good success. It, of course, is quite 3-4 years old. I don't know, Uttam, whether you have joined, you can definitely tell us about it. Then comes the intradiscal procedures. So these are various intradiscal procedures. So you can have a discogram, discography, whether it's cervical, thoracic, or lumbar area. Ozone nucleolysis, which is intradiscal, whether it is cervical, thoracic, or lumbar. Percutaneous disc compressions, lumbar biaculoplasties. Then cervical nucleoplasties, nucleotomies, RF discectomies, and lumbar nucleotomies, nucleoplasties, and annuloplasty. So the various procedures which are done by the pain physicians. Then comes the endoscopic or epiduroscopic procedures, which are also done by the various pain physicians. So epiduroscopy, percutaneous endoscopic foraminoplasty or foraminotomy, either lumbar, cervical, anterior approach or posterior approach. Then percutaneous endoscopic disc decompressions, whether it is lumbar disc, whether it can be a transforaminal approach or interlaminar approach. Percutaneous endoscopic stenotic decompressions in the lumbar or cervical spines. Then percutaneous lumbar interbody fixations without a cage or a graft, or with cage and with graft. So depending upon whether it's a lumbar interbody fixation, which is an expandable cage, or percutaneous transforaminal lumbar interbody fixation. So these are the various procedures which are done by the pain physician, and they have been coded by our own society, ISSP. And how many procedures are done at what level depends upon, of course, we have our guest speakers and the renowned spine minimally invasive pain physicians doing all these procedures. I'm sure they must be doing all these procedures. So this was the list which was published in 2018. I'm sure there must be many more procedures, and this list may be more upgraded. Maybe now nearly 2023, after 5 years, we might upgrade, and many more procedures done by pain physicians definitely can be added to all this list. So this was just a small overall overview. I'll not take a lot of time because we want our guest speakers to enlighten us and encourage us so that we all come into this field. So, so these are the various procedures which I will not go through again. So this was one of the 2 articles, of course, published by Anurag, full endoscopic lumbar discectomy for high canal compromised disc in upper lumbar level. And another, of course, another by Dr. Anurag again, percutaneous endoscopic interlaminar discectomy for superiorly sequestrated disc L5 and S1. So he has been not only working, but also publishing. So we are very happy to have Dr. Anurag Agarwal, and I hope the whole society of Pune, being pain physician, as pain physician, will definitely be enlightened by your lecture. So I ask our moderator, Dr. Amol, to definitely introduce our speaker, guest speaker, Dr. Anurag Agarwal. Thank you for joining. So thank you for this little overview. Yes, Amod.
Thank you, sir. Thanks for nice words and for the overall review of the spine MIPSI.
So I'll stop sharing now.
Yes, sir.
So our next speaker is Dr. Anurag Agarwal, sir. He's pain and spine pain physician and professor in the Department of Anaesthesiology. He is Honorable Secretary, Indian Society of Pain Clinicians. He is founder president of Endoscopic Spine and Interventional Pain Society. His place of work is Dr. Manohar Lohas Institute of Medical Institute, Lucknow, India. His achievements are establishment of pain clinic and pain medicine OT at LLRM Medical College, Meerut, and JSVM Medical College, Kanpur. Also, advancement of the pain medicine services at the Dr. RMLIMS, Lucknow. He has more than 25 national and international publications, and his areas of interest in interventional pain and endoscopic spine management. Welcome, sir. I welcome Dr. Anurag Agarwal, sir, for his talk on the vertebroplasty by the pain physician.
So you can start sharing the screen.
Thank you, Dr. Amol, for the kind introduction. With the permission of chair, I am going to share my screen. First of all, I am really thankful for the Society for Study of Pain, Pune, for giving me this opportunity, especially Dr. Jana and Dr. Varsha for considering me for this honor. I hope by the end of this talk, I should be able to stimulate at least few of you who are still not doing these vertebral augmentation and endoscopy by Dr. Siddharth after my talk to start and venture into these fine, delicate, but very impressive and important pain interventions. So already has been discussed. Recently, I have been selected, whatever you call say, as a member of Pain Medicine Board from the National Board of Examinations, NBEMS India. Coming to the topic, vertebroplasty, as the title says, it is like the repair. Plasty means repair of the vertebra. Vertebro plus plasty. So it is a minimally invasive, image-guided, minimally invasive pain spine intervention, which is used to stabilize the fractured vertebra. And whenever there is a fracture of any bone, including the vertebra, there is a lot of pain. So this is a minimally invasive method to do that. Earlier, we used to do it with the conventional open surgery. Now it can be possible with a minimally invasive method. So to understand what vertebroplasty or vertebral augmentation is, it is very important, like for any other minimally invasive pain spine intervention or the MIPSI, the term given by the ISSP, our own body, to understand the anatomy. Without knowing the anatomy of what you are doing, of the part of the body, or without knowing the fluoroanatomy, as well as without knowing how to use your CRM fluoroscope. Most of these interventions are almost impossible and must not be tried. So again, coming back to the anatomy, this is the thoracic vertebra, because most of the vertebral fractures you will find to see in later on are happening at the dorsolumbar junction. That is D12 L1 area, but it can be
मैम मेरे नाम से
at any place.
अभी जस्ट मैम 2 मिनट पहले जाएंगे.
Pardon? Hello.
Sorry, Anurag. I think so. Siddharth is joining. You continue.
Okay, I can continue now.
Yes.
Okay, thank you. So here you can see at the thoracic level, you need to plan your trajectory. As you can see that this is a conical shape of vertebra. Also, this pedicle, which is very important for us, it has got a slender waist. That means it's a thinner, and it has got a straight. So you need to plan the trajectory.
Not getting connected. WhatsApp call. It's not getting connected. We have to phone connect.
Then comes the lumbar vertebra, our own favorite area for any pain physician. Here you can see that the vertebra is quite squarely or rectangular shape. Pedicles are quite broad enough. And here you can use the pedicle to reach the center of vertebra by using the transpedicular view. So it is very important to understand the AP view or the axial cut and as well as the lateral. Here you can see there is an X-ray, which is again very important part of the workup for any interventions, especially the vertebroplasty. Here, I think that we all can understand this is superior end plate, inferior end plate. This is the spine. These are the lamina, and this is our area of interest, which is pedicle. Because most commonly we use a transpedicular route to reach the middle of the vertebra, which is fractured, and fill it with the liquid cement. And this is the lateral picture. Again, you can see our cannula comes from here to here, reach here, and then we fill it with the cement. So spinal column can be divided into three parts: anterior column, middle column, posterior column. And here you can see, I can show you, this is the lateral depiction of the vertebra, where you can see this part is the anterior part. And fortunately, this part is most commonly involved in the most commonly happening osteoporotic vertebral compression fracture. So this is our area of interest. This is comparatively quite safe also because this area is largely devoid of venous plexus. Then comes the middle column and then comes the posterior column. So middle column and posterior column, which contains the disc, annulus and posterior longitudinal ligament, and posterior column, which contains the canal. These parts are risky parts. If fracture involves these areas, then we need to be careful, or sometimes we even need to refer the patient. So spinal cord and canal, they are located in the posterior column, which is adjacent. This is the posterior column. Here you can see the canal is there. So this area is risky area. So when there is a fracture in the middle of posterior column, they have the potential to impinge on the spinal canal and cord. So what are the indications? The most common indication for the vertebroplasty or balloon kyphoplasty is atraumatic osteoporotic vertebral compression fracture. Most common cause, as the name suggests, is the senile osteoporosis, which happens most commonly into the post-menopausal women, and sometimes also in the younger lot of patients who are on the chronic steroid use because of some rheumatological disease, some dermatological disease, and all that. Sometimes there are other causes, rarely, like Prager's disease, multiple myeloma, hyperparathyroidism. So in these osteoporotic vertebral compression fractures, the curious thing is that there is no big trauma. The common history is कि माता जी बाथरूम गई थी और थोड़ा सा पैर जरा झटका खा गया, ये जरा सा फिसल गई थी हल्के से, लेकिन उसके बाद से उठ नहीं पा रही, कमर में बहुत ज्यादा दर्द. So when you find X-ray, this kind of patient, you get an X-ray and you find the D12L1 vertebra collapsed. So because bones are so brittle, here you can see this is a normal vertebra, this is the osteoporotic vertebra, and this is a compressed vertebra, where you can see that there is a vas compression. Upper and lower, both end plates are depressed. Another indication for which the first vertebroplasty was ever attempted in 1980s was hemangioma. And you will be surprised to know that this hemangioma was at the level of C2 vertebra, so high up. And it was done by Dr. Gilbert at France. Then comes another very common, unfortunately, a reason for vertebroplasty and kyphoplasty is spinal metastatic fractures. The incidence of cancer is increasing, so is the incidence of metastasis into the bone and vertebra is increasing. For the spinal metastasis, it is something I would like to mention here that radiotherapy is the mainstay of treatment, but there are few limitations for radiotherapy. It usually requires 2 to 6 weeks to become effective. And unfortunately, as the literature suggests, only 50% of people respond to the radiotherapy. And so there are a certain subset of patient who is having such an extensive disease that they have already reached to the level of radiation, maximum level of radiation, and now they have a fracture. So what to do? No more radiation can be given, but you need to take care of their pain. So the conservative care starts with these braces, Taylor's and Ash braces, where you keep the spine into the hyperextension, give rest in the supine position, and give some analgesics, NSAID, muscle relaxant, etc., and wait the mother nature to heal the patient. Many times it happens, many times it doesn't happen. So there comes our role. First, as a pain physician, what you will do, what I will do in such kind of patient which comes with a severe back pain, inability to sit or stand after a trivial trauma, we will go for an imaging. And what is the most common imaging? The cheapest and oldest, that is our plain X, AP and lateral. Here you can see that there is a L2 vertebra. This vertebra looks fine. This vertebra looks fine, but this vertebra looks depressed with a depressed superior fracture. I hope that you can see, appreciate. Another thing, after watching the collapsed vertebra on the X-ray, you try to find out what about the pedigree, because this is the route which we are going to use to reach to the vertebra if we want to do some vertebroplasty or kyphoplasty. So here you can see this vertebra is collapsed, anterior wedge collapse. So it is increasing the kyphotic angle also. Another picture, here you can see there are multiple fractures, 1, 2, perhaps this also, but these two are certainly big fractures. But this X-ray is telling us only about the occurrence of fracture. It is not telling us about the age of fracture. Perhaps one of these fractures is quite old one and has already been healed. That's why we need not do anything, but one of them may be active. How to determine about it? Now comes the role of MRI. MRI is the investigation of choice. MRI tells you not only about the fracture, level of fracture, also about the condition of posterior displacement in the canal and the age of fracture. Here you can see on T2 images, this is a T2 image, you can see that there is a big cleft filled with the hyperintense signal, that is most likely edema or water sort of thing, liquid type of thing. So this is something, this is likely to be an acute or subacute fracture. So it also tells you about the extent of disease, whether it is extending to the epidural space, like here you can see that this posterior wall of the vertebra is bulging and almost touching to the caudate column. So this is a metastatic picture. So MRI is the investigation of choice, whether you are going to attempt this patient for the minimally invasive vertebroplasty, kyphoplasty, or you are going to say. When there are cases when MRI is contraindicated, or even if the MRI is not contraindicated, but you are not very sure about the integrity of the posterior cortex, which is this part, posterior cortex of the vertebra, you need to get one CT scan, because it tells you about the osteolytic or osteoblastic lesion in cases of cancer patient, and it also tells you about the destruction of bone in the posterior cortex, which is most important. Here you can see that this whole posterior cortex almost has bone. So this is a very tricky case. I would think 10 times before I attempt. Here also I would think, but still it is comparatively a small breach. Here you can see this is the osteoblastic vertebra. Most likely I'm not going to get a place to put out, but this is osteolytic, so I can do it. So all these investigations are very important. Here you can see that bones, as we all know, that bones are better delineated on the CT scan than the MRI. So here you can see that on MRI it's not very clear, but on CT scan it's very clear. There is a big fragment going into the canal. This is not my case. This is not the VAS compression fracture. This is a burst fracture. It has to be corrected and fixed with the open surgical. So I am going to refer this patient, and this CT has immensely helped me into taking that decision. What are the contraindications? They are absolute as well as relative. First, the burst fracture, I showed you here. This is not my case. Pre-existing neurological deficit, if some patient is coming with the bladder bowel involvement after the fracture, again, not my case. I like to send the patient to the open surgical fixation, fracture related to spinal stenosis, and if the findings of the patient pain and radiological lesions are not matching. It is very, very important. We are not going to treat the MRI or CT scan or X-ray. We are going to treat the patient's pain. So the findings of investigation and patient complaint must match before we intervene. Then there are relative contraindications, previous spinal canal stenosis, damaged pedicle or articular facet. They are relative now, contraindication. Why? Because even if there is no pedicle, I can reach into the vertebral column by using the extrapedicular or inferior end plate approach to the vertebra. So now they have become relative contraindication. Earlier they were considered the absolute contraindication. Then if the vertebral height is decreased more than 60%, then it is considered again a difficult vertebra, or we call it vertebra plana. Again, that becomes technically challenging. So I wouldn't suggest it for the beginners to attempt these kind of cases. If the patient is unable to lie down prone, you can't do it because you have to do it prone and prone position because you want to use the CR fluoroscope. So, how long or how old fracture should be treated? There is a lot of controversy and debate across the world regarding this thing. Currently, there is no absolute exclusion criteria based off time of fracture. We have treated few patients with a history of almost 1 year, but their fracture were not healed, and which we checked on the MRI, and they were painful, and they responded beautifully for the cement augmentation. But usually the duration considered optimal is less than 3-month-old fracture. But now the consideration is that when someone asks me, sir, कितने दिन तक आप wait करना चाहेंगे conservative care के साथ में before you attempt the vertebroplasty? So I ask them a counter question: for how long would you like to wait for a femur fracture before you going to fix it? So they usually say, sir, immediately, as soon as possible. So मैंने कहा यार दोनों तो बोन है ना, फीमर भी बोन है तेरी और वर्टिब्रोप्लास्टी वर्टिब्रा भी तेरी बोन ही है, तो एक की इतनी इज्जत एक की इतनी कम इज्जत, ऐसा क्यों भाई? तो I like to fix them as soon as possible because I like to see them walking on their feet pain free as soon as possible. So another again to emphasize on the contraindication, because as a pain physician it is very important to know that where to put your minimally invasive fine equipment and needles. But it is rather more important that to know that where not to put your fine equipment and needles. So this way you must understand that this is not my case. The use almost 80% of the posterior cortex has gone. This is a metastatic case. It's highly likely when I will put my cement here, cement will go into the direction of least pressure, least resistance, and it will end up into the canal. And there will be a big, big mess, and patient may land into the cord equinus. But here, on the other side, this is a small breach, hardly 10-12%. I can safely go here using some radio frequency or my balloon to make a cavity and fill it with the cement safely. Not completely safely, but relatively safely. Again, this is not my case. Tumor is already extending and involving the canal. This is not my case. So, osteoblastic lesion, as I already told, there is no place to put the cement. This almost the cancellous bone has become the cortical bone. But this is my case. So, all these things need to be taken into account before we try upon the vertebroplasty. Then comes the technical pulse, for which I think this lecture was planned. Pre-intervention IV antibiotic. Please remember, most of us are basically anesthesiologists, but we need to tweak our mind and mindset before we undertake these interventions. These interventions are like full surgery, but in the minimally invasive manner. So you need the complete surgical prevention as well as the complete surgical aseptic measures as well as use of antibiotics and all. And then there can always be a bad day. So there has to be one SOS system available with you where you may need to convert the intervention to the open emergency operation. If in this kind of cases, this kind, if you attempt this case or you attempt this case and it's a bad day and a whole cement leaks into this canal, there is no other way except to do a wide open laminectomy and remove all the cement as soon as possible to save your patient from the catastrophe. So, but as a pain physician, you must not be hindered upon by having this thought, because this is a common word. We all work as a team in the tandem. Don't ever think that whosoever is doing a minimally invasive intervention, be it a cardiologist, gastroenterologist, or anybody, even the skin dermatologist who are doing hair transplant, they don't get the complication. Everybody has their own share of complication. And then there are surgeon friends who help them. And this is a vice versa. When surgeon lend into soup, the other guys help them. So this is the part of game. Then there is a very good equipment availability. It is a must thing. This is something where I would like to spend 10-20 seconds, because many times we try to cut cost. Because as an anesthesiologist, we have been trained and demanded to cut the cost as much as possible. But in pain medicine, it doesn't work. Use the best of equipment, use the best of cement. Do not compromise with the cement quality that I will use only the 1,500 rupees normal bone cement. Use a 8,000, 10,000 rupees Vertebroplasty specific cement while you are doing these interventions, because that will make your life easy and your patient's life safe. So lying prone is the position under the cylinder with cushions to increase the lumbar lordosis. Also decrease the lumbar lordosis. So it is very important, so that the anterior end plates, anterior part of the columns vertebra opens. So what are the mechanism of pain relief? Many people ask this. So they are not exact theories, but multiple theories. Most common theory is the mechanical stability, which cement provides to the fractured bone. And this restores the strength of vertebral body, and that decreases the pain of movement. Then there is a thermal theory. The heat generated by the PIMA cement causes damage to the free nerve endings of the vertebrae, and that causes the pain relief. Then there are approaches. One is transpedicular approach, most commonly used, and then there is a parapedicular or extrapedicular. This is the most commonly used approach. I suggest everybody who is attempting vertebroplasty should use this approach initially. Then you can play in whatever manner. Here you can see that this is transport. The cannula is going through the pedicle. This is the pedicle. And cannula is going through the pedicle. And this is the posterolateral extrapedicular or parapedicular approach, where you are directly landing into the vertebra. So classic teaching is cannula insertion at the superolateral angle of pedicle. But by slight maneuvering, you can also use the gun barrel view, which is more like favorite of the pain physicians. So here you can see this is the AP picture, slightly oblique, and then you can see the good pedicle size, and you can see this small dot, which is actually a spinal needle or a guide wire on the pedicle. So this is in the gun barrel view, and when you bring this oblique picture, into the proper straight AP picture, you find that your guide wire or needle is still in the middle of the pedicle. Here, one very important point is to understand, whosoever is planning to learn the vertebroplasty, that this is the medial pedicular wall, this is the lateral pedicular wall. This medial pedicular wall in the AP picture must not be breached till your cannula or needle has reached the posterior vertebral wall in the lateral picture. I am just repeating this sentence again because this is the single most important step of the vertebroplasty or kyphoplasty, that your cannula, needle or whatever you are using must not breach the medial pedicular wall in the AP picture till you have reached the posterior vertebral wall in the lateral picture. Once you have reached here and you are still short of medial pedicular wall, you are safe. Then you can go ahead. And where to go ahead? up to the junction of anterior 1/3, middle 1/3 of vertebra. If you divide this vertebra into 1/3, third, you need to reach in the anterior and middle 1/3 junction. So once you have placed your cannula in the right and satisfactory position, you have checked it a little picture, you prepare the cement, not before that. Not before that. And once you have made the cement into the consistency of toothpaste, again, very, very important point. Your cement must be into the consistency of toothpaste before you inject it. Not too thin or not too thick. If it is thin, it will go any place. From the small breach also, it will leak. But if it is too thick, you will be unable to push it through your cannula, which is usually the 11 gauge cannula. Then you start injecting. Again, the third and perhaps the last important technical part, always inject your cement in the lateral fluoroscope, and actually in the live lateral fluoroscope. Or if you do not want to use the live fluoroscopy, please push 0.1, 0.2 ml of cement, check it. It must not be leaking into the posterior canal. Look, leakage any place is bad, but leakage into the posterior canal, that is the spinal canal, is devastating. So you must always inject the cement into the live lateral fluoroscope. When you are using multiple level, sometimes there are cases where you need to do it at the multiple level. It is difficult because of this big handle, which the vertebroplasty will have, to use it from the one side. So what you do, you use a stapler, one from right, one from left, one from right. And the maximum level of vertebra worldwide people do are 3, not more than 3, because that increases the chances of complication. Then what can happen? You can see cement, good cement fill, good cement fill, good cement fill, but there is a small streak of cement going into it. So this is usually into the venous plexus. This is usually, if you haven't injected a lot of cement into the vein, it is uneventful, but you need to take care. Then few words about the balloon isoplasty. It is slightly more invasive than vertebroplasty. Here a balloon temp is used to create a cavity so that there is less resistance when you inject the cement into the vertebra. It is believed to restore the vertebral height. So canola placement is same as the vertebroplasty. You can see that this gun barrel view in the oblique view, but you make it AP. There is a lot of place to play till the medial pedicular wall reaches. Yes, here it has reached. Still not pedicular wall hasn't breached, and needle has gone into the posterior part of vertebra. Here, then you railroad a cannula over it, and in the vertebroplasty, if you remember, we stopped our cannula at the junction of anterior and middle 1/3. But in kyphoplasty, you stop your cannula at the junction of posterior 1/3 and middle 1/3. And beyond this, the tip of this cannula, your balloon temp goes, as you will see here. This is the first the drill, and then followed by balloon temp. And then you inflate this balloon with the radiopaque dye, your favorite omnipaque dye. So this balloon, when you inflate it, this restores the height. This elevates this depressed end plate and also creates a cavity here. Then you deflate this balloon, remove it, and fill it with the cement. Yes. So now you can see that this cement is going. So this is balloon kyphoplasty, just to give the idea. So what are the endpoint of fillings? Very common question again. When the endpoint of cement filling is, when the cement, you see the cement in the lateral fluoroscopy picture that it is going beyond the marrow space. Or most commonly, if the cement is reaching towards the posterior quarter of body. Like if I can show you here. So still there is some place I can go, but if I see this cement is reaching here, I will stop. So what is the amount of cement to produce pain relief? Again, there is a lot of controversy across the world. Many people are proponent of filling as much as of cement possible. Many people are recommends that 2 to 3 ml or 3 to 5 ml in the lumbar region cement is good enough to produce good amount of pain relief. In fact, they have found that pain relief is independent of the quantity of cement. So I like to use maximum 5 to 6 ml at the lumbar level and 2 to 4 ml at the thoracic level. But more important thing for me is to when cement is reaching posterior quarter of body. So 3 levels, more than 3 levels, not to be done. Then percutaneous cementoplasty, again, the extension of the same topic. We were talking about the vertebra, but now we can fill almost all the bones in the body percutaneously if it requires. And when it requires, usually it requires in the bone metastatic lesions in spine, pelvis, ilium, femur, humerus, even the sternum. They are very painful lesions. If they allow, not every patient is the candidate for this, we can do the cementoplasty and it provides immediate and wonderful pain. So here, this is one case where you can see there is a metastatic lesion in the femur. Here you can see on the CT scan, and we filled it with the, this is known as femoroplasty, like vertebroplasty, femoroplasty, and patient was immediate pain relief. Another patient, see a buccal mucosa with D4 and left sacral ala metastasis. Here you can see that this is collapsed. D4 is already collapsed, and here in the sacrum region, you can see that there is a big lesion. Yes, here. So this was not allowing the patient to sit comfortably, calmly. So we did a percutaneous vertebroplasty at the D4 level and as well as the sacral ala cementoplasty, that is sacroplasty. And patient was immediately relieved of pain. Another patient, multiple myeloma, very common occurrence, severe back pain. Almost all thoracic lumbar vertebra were involved, as the MRI suggests. But you, as a pain physician, it is your duty to find out which levels are most painful and which levels are likely to be more responsive to our interventions. So we did D11, L1 lesion. We found them painful, and patient was immediately relieved. So now comes the most important part of the talk, that is complication. So as I said, any leakage is a complication. But here, if you can see, this is the vertebra, this is the canal, this is the pedicle, and these are the another vertebra, and this is the intervertebral disc. So this cement is leaking into the disc space. So this is bad. Aesthetically is bad, but this is of no consequence. So it is actually allowed, and it happens sometimes, unfortunately, especially in the cases of old neglected fractures of osteoporosis as well as in the metastasis. Another patient, cement leakage anteriorly, again, not a desirable thing, but again, non-consequential. But it is very important to detect these cement leakages as soon as possible, and that is only possible if you are looking at your lateral x-rays after every aliquot of 0.1, 0.2, 0.3 ml of cement. This is bad. But here again, you can see this is a metastatic case, multiple lesions. There was a small breach, but perhaps the cement was too liquid. It has slightly leaked into the canal. But again, the good part is the operator was vigilant, so he stopped immediately. And this small amount, this should be hardly 0.2 to 0.3 ml of cement. It is likely that God is very forgiving, and this patient must not have suffered from any neurological complication. So it is again very important, and emphasize the point that you must check where your cement is going at every element. Another, through the venous plexus, patient may embolize into the lung, small embolize. Again, a non-significant complication, especially if you have taken care of it as soon as it happens. You are not allowed to fill the cement on 5-10 ml cement into the lungs, because that may create a havoc. And what happens? Many people ask, भैया तुम तो पेन फिजिशियन हो, सुई लिए घूमते रहते हो, जहां मन आता है जहां देखते हो वहीं पे डाल देते हो. I ask them कि भैया ठीक है नहीं करते, आप कंजर्वेटिव कर लो, लेकिन what happens? Can you see? This is our patient, and this is the this is a scientific meet I can share. Same patient, X-ray 23rd April 19, 30th July 19. Hardly July, April, May, June, July. Hardly 3 months. And conservative care, completely bedridden, supposedly completely bedridden. And this was the condition on 23rd of April. And this was the condition on 30th of July. Now, it was a cakewalk for any pain physician who is doing vertebroplasty regular. It is almost a nightmare for any pain physician who is doing a vertebroplasty. But we did it, fortunately, and patient was relieved. So again, as you get older, I would say, not wiser, you get to dare slightly more. Extreme vertebroplasty is still painful because you can see the edema. Nothing much. Patient was not willing or fit for big surgery. Here you can see on the STER images, edema is there. So his fracture is unlikely to heal and is very painful. And we did it, and patient was fortunately good. So these are possible. And you see how can it will be a nightmare for any good anesthesiologist also to make this lady undergo on a general anesthesia and big open spinal surgery fixation. So she was smiling and standing half an hour after the vertebroplasty. So another patient, CA prostate, multiple level collapses and about to collapse. And he was unresponsive to radiotherapy as well as samarium. So we had to do multiple level vertebroplasty. Here you can see the step ladder pattern I talked about, because back is not like a football field, so a small space. So they are very close. So you use the trick and technique to reach the places in one go. And patient was sitting and smiling and walking after 4 months of bedridden and therapy. Another fracture, 1 month old fracture, but you can see such a big fracture, no relief. You can see the pre-op video.
बताओ
पैरों में कमर में दिक्कत है भैया जी।
कमर में कितना दर्द हो रहा है?
बहुत दर्द होते ही पैर कमर
चलना पाते? बैठ में ना पाते?
ना बैठी जाए ना चल पाए भैया।
कब से हो रहा है? कितने दिन पहले से?
1.5 महीना भैया जी।
गिर पड़ी थी?
हाँ।
कहाँ पे?
वो घर ही बिजली रही।
हाँ।
Small trivial fracture. I hope that you heard the voice. Dr. Varsha, Dr. Manohar.
Yes. Yeah, we heard the voice.
It's audible.
So we fixed her with the vertebroplasty, and after half an hour.
चलो उधर चलो
चल तो रही हो। मुझे चलने में दर्द हो रहा था पहले, वो कम है?
कितना कम है?
बहुत कम है।
So this is the magic of vertebroplasty. This is another patient just to stimulate our fellow pain physicians. Yes, they are possible. Here you can, I hope that you can appreciate this vertebra. This was a vertebra. This was also healthy like these vertebra. And then she landed into the soup. She lost her valor. And here we used our little tricks, and then God helped us. Bhagwan ki daya se we were able to fill it beautifully. And here the role of position is very important again. We use the hyperextension of the spine so that this collapsed vertebra that becomes slightly opened up, and rest the job was done by the cement only. No balloon was used, only the vertebroplasty was done. So OVCF, any osteoporotic compression fractures, 70-90% patient experience dramatic or complete relief pain within few hours after the vertebroplasty or kyphoplasty. Even with the new plastic metastatic fractures, up to 80% of patients experience marked reduction in the narcotic requirement or complete pain relief. So there are few assumptions like vertebroplasty or cement augmentation is contraindicated moderate to severe retropulsion of posterior vertebral cortex. But now with the improved technique and especially with the balloon kyphoplasty, some of them can be dealt in the minimally invasive. Loss of greater than height, I have already shown a few cases. Restoration of height, better results. Again, this has been found to be a misnomer. Even if there is an immediate restoration of height with the balloon kyphoplasty or some other equipment like spine jack, they doesn't last. but pain relief is good. And volume of cement matter, we have already discussed it. So the take-home message is that vertebroplasty or cement augmentation is very important and good intervention for improved quality of life. But here again come one more pearl, that it does not correct the underlying cause of vertebral fracture. So do treat the cause, that is osteoporosis in the OVC. As metastatic fractures, most of the time they come through the oncology friends, so they are already under the active oncology treatment. But osteoporotic patients, they need your specialized care of osteoporosis also. It is almost a crime if you do only the cement augmentation and leave the patient for another fracture, because the chance of another fracture in next year after a single fracture is up to 20%. So you need to treat the osteoporosis aggressively. In our practice by the pain medicine team at Dr. Ramano Institute of Medical Sciences, Lucknow, we treat our patient either with the use of teriparatide, and our current favorite is the denosumab, which is monthly subcutaneous. So, to summarize, they are the definitive procedure. Quite less complications are there, fortunately, and they are quite simple. This is my Facebook channel and YouTube channel. If someone is interested, you can connect me. We put our few videos and I would also request and take the liberty of the society officials, especially Jana sir, just to increase the awareness about a lot of work has been done by the seniors like Dr. Jana sir and others. Now we have DM in pain medicine, PDEF of 2 years, PDCC at different places. So I would request all of the younger lot of anesthesiologists who are interested in pain medicine that you please choose one or other option for the formal training in the pain medicine. That will make you last longer. Thank you very much for your patient listening. This is my institute, Dr. Manohar at Lucknow. I welcome all of you whenever you visit Lucknow, come and meet us. Thank you very much.
Thank you, Anurag.
Thank you, sir. Thank you. That was the excellent talk. You have explained everything in detail. And it will really helpful to us. And most of all, it's nice to see the happy faces of our patients.
Thank you.
Sir. Thanks. Moving on to our next topic.
Just a minute, Amol. If there are any questions, please post it in the chat box, and we will be taking questions after the both the lectures. Okay.
Yeah. At present, there are no questions in the chat box.
Let's listen to Siddharth.
Yeah.
Yes, Amol. Go ahead.
Yes.
I had shared the screen.
Yeah. Our next speaker is Dr. Siddharth Verma. Sir is Associate Professor in the Department of Pain Medicine at DYPU University, Mumbai. He is founder at Panesia, India and Mumbai Pain School. He is Program Director for Pain Medicine Fellowship at DYPU University, Mumbai. He is also Consultant Pain and Spine and Pain Physician at Masina Hospital, Bhayapara, Apollo Hospital, Navi Mumbai, Dr. BMH Railway Hospital, Bhayapara, Asian Cancer Institute, Mumbai. He has 6 international publications. He is also editorial member of Indian Journal of Pain. His areas of interest are spine endoscopy, full radiofrequency ablation, regenerative medicine, artificial intelligence, and simulation. He is Vice President of ISA Navi Mumbai City Branch as well as Joint Secretary of Indian Society of Pain Clinicians. I welcome Dr. Siddharth Verma sir on his talk on the endoscopic spine MIPSI by pain physicians. Welcome, sir.
Thank you, Dr. Special thanks to the SSPM for the opportunity. So I will just start sharing my screen. So I hope you all can see my screen now.
Yes, your screen is visible.
Okay, so after the wonderful display of, I think I've never seen such nice vertebroplasties and such great results. So by Dr. Anurag sir. So it's time now to move on to another procedure, which is endoscopy, and this is popularly known as spine endoscopy, and there are various terminologies which I will discuss through this talk. And the purpose of my talk is not to give any technical details, although I have included a brief technical overview, but it is more to focus on how pain physicians can start this practice, or why they should do it, and likewise. So let me go ahead. So why make the fuss? What's the keynote here? So it's often a beginner's dilemma, because as a beginner, mostly people are thinking whether to do it, why to do it, why not to do it, why to start, can we do it, how to start, what are the results, safety, efficacy, etc. And this is going to be an extremely important technique in the armamentarium of a pain physician in the coming future. So it's only a matter of time when everybody adopts to this technique. And I am sure by the end of this talk, I would have proved this and convinced you all to join the bandwagon. So when a patient comes to us, surprisingly, there are many options. Like I'll just post a question to the audience. There are around 12 or 13 people watching on YouTube, and maybe around 15 of us here. So if a patient comes to us with a prolapsed intervertebral disc, which is less than say 20-25% prolapse, and on it's a paracentral compressing one-sided nerve root. So what are the options available if we talk about interventions? Just a brief, if anybody can just type. I want to keep the session interactive, so I hope you all will help me out. So just type in the chat box, guys, and then let's take it on from there. I'm not going to move ahead till I see at least 4 or 5 responses. So I'll repeat my question. Patient comes to you with a prolapsed intervertebral disc. It's a paracentral disc, less than 25% compression. Maybe you have radicular symptoms. What are the options available? Come on, guys. Okay, great. So we got one answer, epidural. So it can be an interlaminar epidural, it can be a transfemoral epidural. Okay, good. Great. Any other options available? Okay, so that's the only option available. So guys, this was what I wanted to elucidate, that there has to be a number of options available in the armamentarium of a, oh yes, we got some good options again. So Dr. Vivek says nerve root block, epidural injection, ozone injection. So ozone injection, I presume in the disc, right? So good. So there are multiple options available. At least some of you have mentioned. But yes. So endoscopic discectomy. Okay, great. Yeah, that's right, Dr. Shan. Good. So there are various options which will be available to you if you are trained to do all these techniques. Then only you have all these various options. If you know only to do one technique, then there is only that one option available to you. So first of all, supposingly you have got multiple options. In that case, you are now puzzled with the question that which one to choose. So then you can decide on various factors based on the condition and based upon the patient preference or your preference, and likewise. So if those options are not available, then the choice becomes really limited. Then you have only one option. एक ही लाठी है, उसी से सबको लगाएंगे. So that becomes quite a difficult option for your patients, and the results will automatically decrease. The second thing is, as you progress through your journey in learning different pain procedures, so most of us here are anesthesiologists, and definitely the complexity of your procedures will gradually increase. I don't expect anybody to start with the vertebroplasty on day one. So maybe you will start with a simpler procedure like a transforaminal epidural, and then slowly build up with increasing time, the complexity increases of your procedures. However, the patient does not know this, that you have started the pain practice today only. Neither his disease knows this. So definitely it is better that as soon as possible, you should climb up the ladder and complete your learning, so that the day the patient comes to you, you are able to offer a vast majority of these options. Now, what to do before that? Of course, it's a very simple solution. You can work in a team. So say, for example, there are 10 people who are doing transfemoral epidurals, and there's only 2 people who are doing vertebroplasty. So you can team up with the people, and then of course you can be present in all those procedures, and then the learning can go on from there. So many a times you will be presented with various options. Like for example, for a simple case of herniation, which I told you before, you may choose to go in for a transfemoral endoscopy. You may choose to go in for just a transfemoral epidural injection. So the decision will be based on various factors, and one of these will be your training. Another one, which will be very common, will be patient choice. And of course, the most important will be what is likely to give you a good long-term result. You don't want the patient to come back to you after 3 months or 2 months and then say, okay, doctor, now 2 months are over and again I have got the same pain. And it becomes very difficult to counsel that patient. And even the practices which repeat the epidurals, it's recommended not to repeat it more than thrice a year. So that's also a very difficult situation you may encounter. Now let's think of this solution. Many times while you are presented with choices, it's only a matter of your personal preference, and at that particular time you may exercise the option. But usually in medical science, this is not the case. It is like, for example, in this picture, no matter what she chooses, you may think that it will have equal effect. But on the if you think chemically, or if you think rationally, all these foods will have different effects, and they depending upon their composition. Now, this brings us to another dilemma which we will face. This is a poster from one of the Bollywood movies. So sometimes you will feel that, okay, let me do this procedure for this patient. It will be helpful to this patient. And at the other times you'll feel that let me do a different procedure. With this background, let me come to the most important part. Now, if I tell you that you have all these bullets in your armamentarium, you can make a choice of the bullet as per the the target. On the other hand, if you don't have all these choices and you just have only one bullet and you have to hit with only one bullet, it's going to be very difficult for you. So it's very important to understand that you need to have multiple procedures in your armamentarium to tackle the different problems, especially in a complicated structure like spine. Okay. So this brings me to the main part of my presentation. This was just an introduction to just outline the importance of this topic. And before I begin, I'll just like to quickly cover the technical aspects of this procedure. So this is a diagram showing the technical layout. And if you see that we will require a different anesthesiologist, so you cannot be yourself the anesthesiologist and also do this procedure. And if you are doing an intervention, so you will stand here where usually the surgeon stands, and you will have a nurse, and this will be your equipments. And then there will be your suction irrigation equipments, and patient lies prone, and patient, please mind it that the patient is awake, aware, and you will have a technician in your C-arm. And this is the basic layout which you will have in the OT. So it's a percutaneous procedure. So you stay on top of the skin and only your instruments go inside, and you are using an endoscope in this procedure. And the C-arm guides you to start with. So the first line which you mark is an interspinous line. The second line which you mark is the intradiscal line, which is the transverse line. And the third line which you mark is the disc inclination line, which shows what is the inclination point of or what is the angle at which the disc is oriented, so that you can actually enter the disc and then complete the procedure. So once you mark these 3 lines, you also measure the skin distance from the tip of the vertebral body till the top of the skin, and you just note that distance, maybe 10 centimeter or whatever. And once you have marked this distance, you can just go from the midline in the AP view. You can mark this perpendicular line to the first line which you had drawn, that is the intradiscal line, and this will give you this cross here. And on this particular line, you mark another point and drop a perpendicular from this line so that you can get a entry point. So this will be your entry point. So I will repeat if it sounds confusing. It's very simple actually. So you mark this first line, this is your second line, then this is your third line. On the second line, you mark this distance, which gives you this cross. And from here, you draw a perpendicular, which intersects the third line. And this is your entry point. This is a way to start the procedure. With practice, you may not need to draw all these lines, but for beginners, it is highly recommended that you start in this way. Once you put in your needle, you just thread over the dilator and the cannula. And this cannula helps us to put in an 8 millimeter. This is an 8 millimeter outer diameter cannula. And this helps us to put in an endoscope, which often has around 4 millimeter or 3.9 millimeters of internal diameter. So this is these are the sizes which we are working with, and you can very well understand that it's a very small size. However, the visualization which you see is excellent because the magnification at which we work, it is the same like you assist to a laparoscopic surgeon. In fact, it is much better. Rather, I would compare this with a urology procedure, and you will find that a very small, when you are assisting with a TURP, and all of you must have assisted in that case. So you can see the small structure in a very big magnification, and this makes the procedure very easy for us. Now let us compare this with a dorsal approach. So usual approach, if you were to approach, will be like this. This is a cadaveric study. This is the head end, and this is the foot end, or the cranial and the caudal, and this is the facet which you can see. This is your nerve root coming out, and here is the point where you give your transforaminal, which then goes along the root. And our scope enters the spine using this God-given intervertebral foramen. And there's no bone cutting or nothing is involved. It's not, you don't need to do any major bony work. And once you are entering inside, it's almost quite clear and unambiguous to remove the portion of the disc which you want to achieve. And there is a lot of maneuverability which you can achieve through this this facet. You can use it as a fulcrum, and you can achieve a significant amount of maneuverability, using which you can pull out all this herniated nucleus out, and without damaging the healthy disc, you can easily do this procedure. So there is another technique which is known as outside in. So I'll just skip it. It's very similar technique. The only difference is all the lining, everything is exactly the same. Only difference is here you land on the facet joint, and the first structure which you see is not the disc, but you are outside the disc. That's why it's known as outside in. So it's other than that, it's quite similar. If time permits, I will show you the video demo of the technique later on. But before that, let's move on to kya farak padta hai, why we should actually do it, why not, and why it is a natural progression for any pain physician to naturally grow to this technique. So this is a traditional approach. So let me call it ye hai aam zindagi. And this was the surgeon's approach which used to happen. So many of you would have assisted many spine surgeries. So this is the approach which they will use. So to summarize, this is the structures which are to be protected. This is the structure which is to be targeted. So they use a nerve retractor to just push away these structures using a tube or various modifications of this tube, and then they catch hold of this disc and come out. On the other hand, of course, this requires general anesthesia. You have given yourself, many of you have given general anesthesia in these patients. On the other hand, the transforaminal approach, it utilizes the God-given epidural, the intervertebral foramen. And if you see, this green line is the approach which is taken, and it straight away puts in the endoscope into the target area. And then you can, of course, maneuver and manipulate. Only the thing which you need to take care is the correct targeting. If the disc is here, you need to go here. If the herniated disc is here, you need to go here. If it is here, you need to go here, and likewise. So there are various small modifications, like this one is the outside in approach where you land on the facet, as I was saying earlier. And this one is the far lateral approach, which is used. So these are modifications which can be learnt later on. But per se, the procedure is quite straightforward, and there is nothing which is complicated. Only the thing is that you need training for this. Of course, you are already perfect with the needling part, so needle and targeting all is quite easy for a pain physician. But the rest of the part needs some training. Now let's see why a spine endoscopy is gaining huge importance in the recent times. Now, I was going through the literature, and on Sunday, I was presenting the same talk in a conference which was attended by neurosurgeons and spine surgeons from throughout the world. This was happening in Mumbai, and I presented the same slide. And the key here was that a very important paper was published as early as 2016, and it was published in a pain journal. So what they are outlining here is that percutaneous endoscopic lumbar discectomy as an alternative to open lumbar microdiscectomy. So it's already heralded as an alternative for large lumbar disc herniation, which is defined as a herniation occupying more than 50% of the spinal canal. So it's not a very small herniation, or there is no ambiguity about it. And this group, they found that there was no significant difference in the leg pain improvement. So here you have got a technique which can adequately address the problem and at the same time give you excellent results. And the satisfaction rate was even higher because the patient can immediately walk after the procedure, and mean operating time, hospital stay, etc., is quite shorter. And these are the biggest advantages. But what I want to focus on here is that the disc height is decreased significantly in the microscopic lumbar discectomy, while on the other hand, it did not change significantly in our procedure, which we routinely do. So this is a very important point, because this increases the longevity of your disc, and this kind of helps the patient to utilize the same set of organs for a longer period of time. And there's no collateral damage, so it's quite minimally invasive, which is I would say the hallmark of our branch, which is minimally invasive procedures. Now let me take you back to even earlier techniques, earlier times, and even as early as 2013. Unfortunately, again in 2013, there's a paper by Dr. Kim et al. And they say that there was a very important point which they found out, that while coming out after finishing their procedure, they used to do the radiofrequency ablation of the rent which they had created while they were going inside the disc. This simple step greatly improved their results and reduced their recurrence rate. While I was going through this procedure, I found out that this is what we are doing as pain physicians when we are doing the radiofrequency ablation at the posterior portion of the disc. So this is extremely important, that what you could do without vision now, you can do under vision, and that too by the patient is your live monitor. The patient will actually tell you real time what are his painful structures. So many times when I'm doing this procedure, I would ask the patient that please identify your painful structures, and they would help me to identify the painful structures so that I can actually target them. So this is something which is not available in any other technique. Just imagine in your lumbar surgery or any whatever usually is done, the patient is not awake and aware. The patient is under anesthesia. So you can forget about the feedback or the nerve protection, which is another advantage of this procedure. You can actually have an exact feedback from the patient, which can be very valuable. So there are variety of these kind of trials and this kind of recommendations which are available. I'm not going into the details, but the key here is that a greater revision rate, which is touted to be the most, by the detractors of this technique, it is offset by a more rapid recovery. So you can, for example, my patient, I can do endoscopy even in a 80-year-old female 3 times. On the other hand, even if you have a 60-year-old female, it's very difficult to do an open surgery even twice. So that's the kind of difference which we have, in our technique. So so it's very clear that that data is piling up in favor of endoscopic techniques now, and this is going to be the future not only for us, but in recent times even more and more surgeons are going to adopt this technique, rather than going for the open procedures. Now let me bring you to another very important paper which compares different techniques, 8 different interventions, out of which around 5 are the ones which are used almost exclusively by pain physicians. So the first one is automated percutaneous lumbar discectomy, chemonucleolysis, then microdiscectomy, the standard one, microendoscopic discectomy, open discectomy, then PELD, which is the endoscopy which we do as pain physicians. The commonly used term is percutaneous endoscopic lumbar discectomy, or PELD, and percutaneous laser decompression. So you can see, other than these three, all the others are almost exclusively done by pain physicians. And they found even they added a tubular discectomy, and they found quite starking revelations. And they found that the percutaneous endoscopic lumbar decompression and PLD, which is a laser decompression, had the most lowest intraoperative and postoperative complication rates respectively, and the others had they were the safest procedures according to complications, and of course the results were much better with them as well. Now this brings me to the next question. Many of us will agree to me by the time I'm ending, so just get ready to type, guys. I need a response from you. I am going to show you 3 procedures. This is the first one, this is the second one, and this is a transforaminal injection, and this is the third one. So what do you think, which is the most complicated one? Come on, guys, let's have some answers fast. I understand it's already 9:25, but I'm not going to exceed the time allotted to me. Just tell me, this procedure is complicated, this one, or this one. What do you say? Okay, I have one answer. Endoscopic discectomy. Great. Second, Dr. Idma says the third one, that is the endoscopic discectomy. Okay, great. And then Dr. Vivek says nerve root injection. Dr. Nankar says first. Great. This was what I was wanting as the answer. So guys, please understand, the complexity of procedure does not depend on the procedure itself. It depends on the physician's training. This point is to be noted, that if you are trained in doing the first procedure, which is just dry needling with a needle, then definitely you can do that procedure well. If you are not trained in doing that, I'm sorry, but unfortunately it looks very simple. Ek sui uthai aur kidhar bhi ghusa di. But that's what it looks to a patient, but it is not that simple. So on the other hand, if I am trained with endoscopic discectomy and I am doing it day in, day out, so it is just like a second reflex for me. All my staff is trained. When I come, they keep everything ready. Sometimes I have to shout a little, but then I know that the things would be done. Things are in my control and I can do it very easily. So it's extremely important. The second one is definitely not the easiest as well. So what point I want to make is, it's a matter of your training, how well you are trained. So there's no fun getting afraid with any procedure. It's only a matter of training. You spend time in training and you would be good with any procedure. It is just like if I tell this, all this example, this common example which is given for a fair selection, everybody has to take the same exam, and then they tell all these monkey and sparrow and everybody to climb the tree. So is it a fair exam? You will say no. Now if I ask you, can a fish climb a tree? What is your answer? Keep typing, guys. Good, I can see some good response. The YouTube guys are not typing, but it's okay. So maybe they're watching on the TV. So on the Zoom, I want everyone to type. Can a fish climb a tree? Okay, Ridhima says no. Great. Anybody else? Koi to yes bolega. Okay. No, I think some people are Googling. That's why I'm taking more time. So let me come. A common person will think that a fish cannot climb tree? Yes, we have one more answer. Just let me check. Okay, Dr. Varshali says yes, and yes, fish can climb the tree. Can you believe it? Fish can climb the tree. So this is a fish which climbs the tree. So it's not the matter of how, it's a matter of, rather I would say it's a matter of training. The fish has trained itself. It is evolved. I will use the word evolution. That's how evolution happened. Not only climb the tree, they can fly also. Of course, for short distances, but they can fly also. So this is something which I want to emphasize more. Technique is a different story. I cannot teach you the whole technique in one go. But definitely I can instill the confidence in you that you all can probably get proper training and then maybe try to enter this field. If even elephants can swim, so it's not very different. Anybody can guess the location? It's in India. So many of you would have gone there also. So just remember these pictures whenever you think that you cannot do this procedure. It's only a matter of training. Now this was a little philosophical. Now let me come to practical thing. So is there a learning curve? So I was very fortunate to attend a live lecture by Dr. Anthony Young, where he was talking about the learning curve. Dr. Anthony Young is heralded as the father of spine endoscopy, and he was one of the initial people who developed this, the endoscope, or developed the first endoscope. So they thought that let us establish why the surgeons cannot learn endoscopy. Can you believe it? We are talking about anesthesiologists not being able to learn endoscopy, and here are some people who are writing that surgeons even cannot learn it very traditionally and very, very easily. So it's not about whether you are a surgeon or whether you are an anesthesiologist. It's about how you are trained, with whom you are training, what is your approach, and what is your attitude. So they have published this paper, and they have found that the need for implementation is identified, which I think, clarifying today. So I am already putting you at this one or probably second target group. Identify target patient group, which is your target. Identify the endoscopic procedures or surgeries to learn. They are called as surgeries because actually you are going inside and doing micro manipulation. So don't be scared of this word surgeries. Because most of us are already doing some form of these procedures. Then you have to attend professional society meeting and courses like this one. Then you practice in cadaver workshops. This is what they have recommended. Then identify a mentor and observe live procedures or surgeries. Then you overcome these barriers. If you are able to overcome these barriers, then you employ a reliable diagnostic prognosticators. That means you have to then procedures and then go there. Now just imagine, this is the point where I want to draw your attention towards. So since this is for surgeons, so they have mentioned practice selective blocks, disco and epidurogram. So I think almost all of you are doing this every day and day out. So maybe you I think yahan tak to ho jayega barabar. Then start with simple far lateral herniated nucleus pulposus, then expands to paracentral. So then they have explained how to go about it, and then analyze and contribute and present and publish, which nowadays we are doing, teach others, and then become a mentor. And then probably I will use the word become a master spine endoscopist, and likewise. So guys, it is not something which is rocket science. There is a scientific way to it. You just need to understand and grasp, and then slowly go on from there. Of course, many of you will be at career stage or age where you may not want to go for it, but that's perfectly fine. However, the technique is extremely popular, and it's gained a lot of importance in especially for the young pain physicians, and many of them are adopting it. Another point which people ask me is about the legality. So ISSP in 2019 has taken away this problem from you all. I started doing this in before this, but definitely for you it's not a problem. Even all these advanced procedures are now covered in point number 8 in the ISSP coding system. Before this, we used to follow the ASIP guidelines, which had explained these procedures in their codes much earlier. But of course, there is no now. Don't be scared or afraid, and just make sure you are safe and your patient is safe in terms of training. Now in India, we have around 20 university fellowships available. There are around 12 places where the society fellowships are running. There are separate workshops and conferences which are specifically focused on this technique. So there is plenty of training available. There are around 8 or 9 mentors in exclusively pain physicians who can train you now. So I don't think there is any problem for those of you who want to learn the procedure. So coming to my personal opinion, even in endoscopy, there are various techniques which are available. You can do a median branch radiofrequency ablation with endoscope. So there's no, you can start as small as you want, which I do probably with a cool radiofrequency needle. So you can do that also endoscopically, but you just see what technique you like, what you have a quiver and what arrow you will like to have in your armamentarium that you learn. And then you start one by one, master one technique, then the other one. Get result oriented and not technique oriented. हर पेशेंट आया हमको तो ट्रांसफोरामिनल एपिड्यूरल ही लगाना आता है, हम वही लगाएंगे. So rather than that, focus on the result, whether that patient is going to benefit from that technique or not. It is extremely important because you will be considered a good doctor not when you will do a good endoscopic procedure or a good dry needling. You will be considered a good doctor once your patient will have a good relief. So focus on that aspect. Then the patient safety should be of prime importance. Don't risk. Don't probably it's very unwise to risk the life of the patient for anything. So that's very important. And of course, we colleagues are always here to ready and to help you all. So these are my references. I have some, if the time permits, I can take on videos. Otherwise, we can have some future talk.
Siddharth, fantastic talk. I think it was an eye opener. I think so. Hardly any questions in the chat box. We were absolutely all listening to Anurag and Siddharth. Amol, can you take forward from there? If there
Thank you. Such a nice, informative session it was. You have explained everything in the details. Now, moving on to the question answer session. There is one question in the chat box. It is by Dr. Uttam Sidhe. Sir is asking when to choose kypho over vertebroplasty. It's for Anurag Agarwal, sir.
Anurag, yes.
Yes. Okay. So actually, the vertebroplasty was the one which was discovered earlier, and then actually, as I told you, that it was discovered by a radiologist, intervention radiologist in France. Later on, surgeons felt that they need to do something else, so they brought a balloon in and they started the kyphoplasty. But later on, we have found that kyphoplasty has certainly got some benefits and some disadvantages over the vertebroplasty. I personally choose kyphoplasty when there is some doubt about the posterior integrity, some doubt. Not as clear as I showed in my few of my slides that there is a big breach in the posterior cortex. So no vertebroplasty or no kyphoplasty. But when there is a small breach and I want to use the thicker cement during the augmentation, I like to use a kyphoplasty because kyphoplasty creates you a void which allows you to push the thicker cement than the vertebroplasty does. So this is one. Second is again, kyphoplasty is a costlier thing. In comparison to vertebroplasty, is quite costly. So in India is the reality. Most of the patients are paying from their own pocket. So we have to see the patient pocket also. But certainly there is one more advantage, at least by book, that kyphoplasty is capable of increasing the height of the vertebra. So especially in the younger lot of patients, she is not a 80-year-old female where it doesn't make any aesthetic sense to increase the height. But in the younger lot of patients in 40s, 50s, I like to use kyphoplasty because I want to give them as best aesthetic as possible. So I hope that I have answered that.
Yes, definitely.
Yes.
Bye-bye.
Yes.
Yeah. You can ask your questions directly.
Any difference about the embolization in the kyphoplasty and vertebroplasty? Chances of embolization is less in
Embolization,
kypho and
venous embolization you are asking?
Yeah.
No, perhaps literature suggests that there are more chances of leakage with kyphoplasty. But on the other hand, there are less chances of leakage, at least in the venous part, with the kyphoplasty because you are using thicker cement. With vertebroplasty, you are using more liquid cement. So there are chances. This is why our team, we do not promote the venography before doing the cement injection, which many of people do actually, because there is a lot of difference between the consistency of the dye and the cement, whatever you are using in how much liquid form, but it is going to be thicker than the dye. So where your dye will go, cement is unlikely to go. So we do not personally promote to you do the venography, which many of the authorities do. So take your pick. We do not have any straight answers.
Yes, Amol, there's one more question in the chat box.
Yes, sir. There is one more question from Dr. Vivek Deshmukh. He's asking injection of cement in vertebroplasty. Do you prefer 1 cc syringe or 2 cc or 5 cc?
Very good question, Vivek.
Good question.
Very good question. And I would suggest that we always use only the 1 ml syringe. Look, there are, again, India is a cost-sensitive country. We have got dedicated kits with the dedicated cement injection system and cement mixer system. But our patients' pocket, most of the time, they don't allow us to use those costly components. So what we do, we use 1 ml sterile insulin syringes. The best part of that, using that syringes, is that it gives you precision, which is the key of the whole game. Because I stressed, I think, enough upon the using live lateral fluoroscopy, or if you are not using live lateral, at least use it after every 0.2 ml. So it is not possible almost practically to check 0.2 ml on a 5 or 10 ml syringe. But it is definitely possible to do it with the 1 ml. So we always use 1 ml syringe, and I would recommend you that you also start using 1 ml.
Yes, also ask, sir, after what time you start injection? Cement time.
Actually, yes, this I actually mentioned. Please always use the vertebroplasty specific cement. When I am talking about the cost sensitiveness of the society, it is not bigger than the patient safety and your own safety. Correct. So please do not compromise with the quality of cement, because let me tell you very clearly, the normal common cement, which I am using the word of company, sir, please forgive me for that, this for the scientific discussion. Yes. Striker cement, half strength, that cost around 1,300 to 1,500 rupees. The common cement which we see using our surgeon friend in the orthopedics, in the spine, open spine also. But vertebroplasty cement usually cost around 8 to 12,000 and costlier than that. So I would always suggest that you save your money in the cement mixing thing. You save your money in other things, but please do not try to save your money in the cement. Use the vertebroplasty specific cement. The reason why I am saying this, the common striker, I am again using striker word because this is the most commonly used cement in the country, at least I know, by the ortho and neuro friends. And that gives you hardening time of hardly 1.5 minutes. 1.5 minute के बाद वो पक्का hard हो जाता है, usually 1.5 से 2 मिनट के अंदर. So you get panicky कि सीमेंट जम गया और अंदर मैंने डालना है तो पतला डालो मोटा डालो, you get panicky. But vertebroplasty cement gives you, because of their physical properties, this is why this is costly, it gives you around working time of 8 to 10 minutes. In whatever consistency you start using it, it will remain in that consistency for 8 to 10 minutes, which becomes a huge relief and safety margin for you as well as your patient. So I would always recommend that you please use it in the toothpaste consistency. And you then, if you are using the proper cement, There are authorities, there are masters who can use any cement. You give them that कौन सा होता है सस्ता नहीं है अच्छा वाला कौन सा सीमेंट रहता है बांगर सीमेंट तो वो भी उसको भी यूज कर डालेंगे and with the wonderful results. But for all the beginners, I would request and suggest that please use the Vertebroplasty specific cement. So वहां पर पैसा नहीं बचाने का है. And that gives you an ample amount of time actually. 10 minutes time almost to work with.
Okay. Dr. Anurag, I have a question.
Please.
As you mentioned, there might be chances of, small leak of the cement. And if it leaks and it stays there for that time being, but later on, like sequestered disk, if it gets disconnected, are there chances of any canal complaint? Like, is there any data or anything?
I haven't come across that thing. Cement is like a static thing. Disk is still a more largely mobile thing. Siddharth will also comment on that. Cement, once it is there, it is going to be there. So I haven't come across that some cement has leaked at some place and it has moved. When it will move if it is in the vein, but in the canal I haven't come across. But yes, anything can happen in medicine. So the single most important thing is that first the leak should not happen. If it has happened, you must acknowledge and recognize it as soon as possible. So this is the two important things which I would say.
One more question to Dr. Siddharth. As you said that it's a mental barrier to learning. That's the best part of it. So I would like to ask how many cases of endoscopic spine we need to assist or see with the expert surgeon as an interventional pain physician to start endoscopy.
So they have actually in the same paper they have documented. They said 15 cases you have to assist, and the 16th you can be as good as probably 80-90% of what an expert will be. But I feel that is for surgeons. For the for us it is much easier. You'll ask me why. Because most of the most important part of a spine endoscopy procedure is the needle targeting, which we have the basic concept in. We don't need to learn the needle maneuvering. We don't need to learn how to keep the bevel. We don't need to. All these concepts are like very basic for us. And also the CIAM is for just see an orthopedician using CIAM and just see a neurosurgeon using CIAM and then just see a pain physician using CIAM. So it is a hell lot of a difference. Everybody uses because they use it for a particular reason, or maybe see an intervention radiologist use a CIAM. So it's altogether a different. Everybody is using the same CIAM, but the way they use it, your technician will tell you. You ask your technician, so they will tell you that what is the difference. They will in fact say, "Yaar doctor, आप तो इतना ऐसे लगे रहते हो, छोटा-छोटा ऐसा देखते रहते हो." वो सर तो आते एक शूट मारते उसी में उनका हो जाता है ना. So there are a lot of differences because of which you are favored to reach. Once the target is reached, then after that you have to learn for the dilation part and all that, and that is also easier for you because you have been using Seldinger technique since like almost donkey's years. Right. So now remains after आपने scope डाल दिया and फिर क्या करना है. तो वहां scare क्या होता है? Mostly we are scared of bleeding. और ये bleeding हो गई तो क्या होगा, complication हो गई तो क्या. So boss, nobody told you to do it alone. It's a teamwork. You can keep your ortho friend with you, or you can keep your neuro friend with you, and they can assist. It's a teamwork, as I said. And maybe they learn 2 things from you. Maybe you learn 2 things from them. All orthopedic surgeons are not going to learn this from their mother's womb and then come. So there also will be learning at some point of time. It's the training for them also. Maybe you can teach some needle tips to them. Maybe they can
skills rather give us a better edge. That's what you say.
So I feel it's a matter of just a few initial. The key is safety and not getting overconfident before. In fact, even if you get overconfident in your 100th case, let it be a vertebroplasty or let it be probably a celiac plexus block. So that is the death of you. You are an interventionist. You are dealing with micromillimeters. You are not you are वो नहीं है कि स्टिच लगाना है फोरहेड पे स्कैल्प का सुचर करना है, कैसे भी कर दिया, जुड़ तो जाएगा ही. It's not like that. You are dealing with the micromillimeters, so you have to have that kind of precision. There is no people ask me, why it is not an MD, why it is a super specialization? Because you need that kind of a mental maturity. In fact, because of my personal experience, I have come to know that people who are less mature or less old in the profession, they are less suited for being an intervention pain physician. This is what I have, this is my experience of teaching people for like quite some time now. So it's better to have that kind of it's a mindset. It's not it's not about technical job is a different thing, but the mindset is more important than the technical job. Correct. You need to have that kind of, I will use the word integrity. So that integrity has to be there, which comes only with maturity. So I will suggest, in fact, the senior ones are more suited to it, and they should just mentally break the barrier and just it's of course.
Yeah, hello Siddharth. Yeah, good evening everybody. Wonderful presentation, though I joined late. Dr. Agarwal and Dr. Siddharth, thanks for giving your, enlightening all of.
Ma'am, you're on mute.
Sir, there is one more question from Dr. Vivek. He's asking if venous plexus is suspected, then prior do you do embolization?
Look, it's not embolization is not specifically required. It's a kind of, you put a thick cement, it's automatically going to get, and you are doing it in a live shoot. I have actually seen spreads in, if you search literature, you will see the many times the spread can be the cement can flow in the veins, and it can create a pattern also, which will stay there for life. And I don't think you need to specifically target ke abhi embolization ho jayega. Yes, one technique which we use is that you start with a thick cement, you pack the anterior portion, then slowly you go on giving more and more cement in aliquots. That is, you give small amount, then check, then give small amount, then check, do live fluoro, and then just before you are going to reach the end point, you just take a final shoot and then you stop. It's not important to fill all the space with all the cement which is possible. Even they have seen even 1 cc, 2 cc of cement has given wonderful results. So don't be focused on the cc you inject कि मैंने 10 syringe भरा था, 18,000 का cement लाया था और यार उसमें तो 2 ही लगा. Your patient relief is extremely important. सारा नहीं घुसाना उसमें. So that is the key, that the correct point and the correct spot. You cannot always in interventional pain remember the basic point, which I will reiterate again and again. Don't overcompensate for your faulty technique by more use of your drug. This is the number one mistake which people make. If your technique is faulty, your needle tip is not at the right place. Many exams they say needle tip dikhao. Why they focus on the needle tip is because if that tip is not in the correct place, अब ये नहीं कि अच्छा चलो वहां आधा सीसी देना था, थोड़ा दूर है, एक दे देते हैं, पहुंच ही जाएगा उधर. The plane is different है, it will go somewhere else. So that point is to be kept in mind, and there is no need of specific embolization because you are not sure what you are. If it were one artery or one vein or one thing, you would have done that. But there is not sure. It's a plexus of veins. So how you can be sure and what to embolize, what not to?
Yeah. Hello. Am I audible?
Yes, ma'am.
Good evening. Yeah. Thanks for the excellent lecture, Dr. Agarwal and Dr. Siddharth. I have one question, especially for the juniors who are attending this. While performing, yes, as you said that break the barriers, get the training, do hands-on, everything. But if any medico-legally, how safe are we? If anything goes wrong, I know.
You missed that slide, but
maybe.
I have taken that. You can review just for
sure.
Just summarizing in one line. So it is now very well established procedure in pain medicine. When I started, it was only in the US it was mentioned and all that. But now even in India or our own society, which is the mother body of the Society of Study of Pain Pune, that is the ISSP, it has given in 2019. It's published in the journal. So I don't think it's not a big deal. Yes, but anything will require you to demonstrate adequate training. So
but who will certify that? Adequate, that word is so vague.
No, it's not vague, madam. It is absolutely, clear, and you need to have observed and performed these cases under supervision to demonstrate your skill. And for example, if you have not done the epidural and something happens, so the thing will go back to your training. By virtue of you being an anesthesiologist, you don't, have any privilege.
Agreed.
In this regard. Same thing will happen if you are doing a cardiac anesthesia case and something happens to the patient, then and you are responsible and they prove it, so then it will all go to your training, that okay, how many cardiac anesthesia cases were administered by you, where you have trained, who was your mentor, show me your logbook, and all these questions will come that time. So it's not specific to endoscopy or to vertebroplasty or to any particular thing, but in general, all medical procedure. If you recall, I don't know, it was a very popular case. One MD medicine, the doctor, he just did a pleural tap, which even I have done while I was doing my internship. And
that's a part of your curriculum. The MBBS
yes.
Or the MD anesthesia.
Yes,
all these procedures are part of the curriculum.
But madam,
I don't know whether endoscopy is included, because nowhere the curriculum is stated.
Yes,
that was
madam,
just my query. Yeah,
it is stated.
Agreed.
In, like when we did our postdoctoral certificate course from the Banaras Hindu University, it was already stated there. And in most programs, it is stated. Well, all my fellows have this as a curriculum. They observe these cases, and I don't think there is any ambiguity about it. Especially now, if you would have asked to me in 2013 or 2014 when if the things were starting, then probably. That time maybe there would have been an iota of doubt, but then also we used to answer to all the colleagues, and it is not this versus this. Please understand, it's a teamwork. Spine especially is so.
Yeah, that's what. So for every case, you mean to say there has to be.
Yeah, if you are
standby or
if this thought is coming in your mind, that itself shows that you are not confident. Or you are means I don't mean you, but the
agreed.
person who is thinking about this. Then I suggest strongly that they make a good team. They need any case can go anywhere. Why you want to risk your career on it? You make a good team and work.
Yeah, that's what I wanted to enlighten for the juniors or for the newcomers, fellows who want to venture into the endoscopy. Any say, Dr. Agarwal? Yeah.
Yes, ma'am. Ma'am, it's not the part of MD anesthesiology curriculum. Please understand. By becoming an anesthesiologist, you do not become a pain physician. Pain medicine is a distinct super specialty of anesthesiology, and for which one need a dedicated training. This is why in the last slide of my presentation, I showed the learning opportunity, as Siddharth also did, try to do. So, but in most of the curriculums, be it DM, PDEF, FNB, PDCC, fellowship at Siddharth place and many other places, it is the part of curriculum, but part of curriculum of pain medicine training, not of MD
that I agreed.
So, ma'am, so it's not a second thing. Just a moment, ma'am. Second thing, as Siddharth has said, our society ISSP has already included into the list of MIPSIs, as Dr. Jana in his talk rightly showed upon. Apart from that, even the government has started recognizing it. And recent guidelines from the Ayushman Bharat, that is PMJ, these guidelines have endoscopy spine discectomy allowed for the pain specialist also. They have used the term pain specialist, not pain physicians, but that is okay. That one and same thing. So this is allowed there also. So rest, as Siddharth suggested, your one who is doing, he has to prove that he has been properly trained. These are new fields, these are the new areas, and they are new for everybody. So it is endoscopy is as new as for pain physician as it is for the neurosurgeon, as well as for the orthosurgeon, or anybody radiologist, or anybody who is performing.
Yeah, thank you so much. That was a good point. So as all our junior fellows come to know, and they can feel free to go ahead with if they have any doubts that got cleared. Thank you so much. Thank you, Dr. Agarwal and Dr. Siddharth. Thank you.
Yes, fantastic discussion. Thank you, Anurag and Dr. Siddharth. And there's been a debate whether the pain physicians can do spine surgery, endoscopic spine surgeries. And I've been hearing this debate for more than 6-7 years. Siddharth and Anurag, you must be also hearing those same debates every conference, panel discussion, debate whether to do or not. But you have cleared the points. Fantastic. So I encourage all pain physicians to go ahead with the training, workshops, fellowships for doing endoscopic spine MISP. So I hand over to Amol, and then we can close the session with Varsha.
It was very nice to hear from the stalwarts in the field of the pain medicine about the spine. Now I hand over the session to Dr. Varsha for the vote of thanks.
Yes.
Now it's over.
I would really like to thank Dr. Anurag Agarwal and Dr. Siddharth Verma for joining and giving this never before attended, so interactive and brainstorming piece for each one of us. I mean, absolutely. It's very honest and authentic opinion. Again, thank you so much for the discussion and straightforward to the point topic and elaborate overview. So it was a privilege for SSPP to have you all. Again, I would like to thank our SSPP team speakers and moderator, Dr. Joyshankar, Jana, and Dr. Amol for helping me conduct this session. All SSPP team for giving their valuable inputs, and our technical support, Anesthesia TV, who has taken this meeting live on 6 platforms. So we were live internationally on 6 platforms and it is available online. So thank you once again, and I declare we close this meeting now.
Thank you.
Thank you.
Thank you very much. Thank you, SSPP.
Thank you so much.
Sir.
Thank you.